Hello, everyone. Welcome. Happy New Year to everyone. To those I haven't had the chance to speak to yet. Thank you for joining. I see many names popping up. So maybe we give it a couple of maybe 30 seconds or so, just for others to join. I hope you can hear me well. Maybe a thumbs up would help. Thanks, Philippe. Great. Okay, maybe we can start the session already. So welcome everyone, and again, thank you for joining today's SRS webinar. The topic for today's session is country resource mobilization plans, focusing on funding goals, also types and sources of support, and as well activities planned beyond the current grant period. And with this session, we aim to foster some cross-learning across countries by sharing different approaches to resource mobilization and sustainability planning. As usual, we'll have 60 minutes in total, and we'll hear from the different countries participating in the planning grants in the following order. So just so you are aware of when your turn will be, we'll start with Kenya and then move to Pakistan, Senegal, Ghana, Tanzania, and Mali. Because we have many presentations, each country will have like a 7-8 minutes to present, and it will be followed by a brief Q&A at the end of the session. I hope you can hear me because I've heard, yeah, because of the messages in the chat. Is it okay for everyone or? Okay, thank you, Maria. Great, then we'll get started. Well, let us begin with Kenya. Mercy, I think you are to present, so the floor is yours.
Yes, thank you, Patricia. Are you able to hear me?
Yes, yeah, we can hear you.
Thanks. Share my slides. You able to see my slides?
Yes, we see the PowerPoint, so not presentation mode, but
hello, I can't hear anybody.
Hello, Professor Bawa.
So this was at your neighbor's house.
Yes, the neighbor's house. Was in the
Maybe Mercy.
Should I go ahead?
Professor Bawa in the chat, so yeah, maybe you can go ahead and hope we can resolve the.
Okay. Thank you, Patricia, and thank you, everyone. I'm going to present on behalf of Kenya on our resource mobilization plan for SRS. Once again, I'm Mercy Chepto, and I'm the coordinator for mortality surveillance at the Kenya National Public Health Institute. So to start us off, this will be my outline. Going to present on the country overview, the current gaps, and the rationale. Then we look at the overview of the SRS, Resource Mobilization Plan, our funding sources, our status of our resource mobilization, and activities for submission of our proposal. So a bit of a background about Kenya health system. We have a devolved health system where we have the counties and the national level. So at the 47 counties in our country, where service delivery occurs, and at the national level where we have the policy, standards, and strategic direction. So Kenya was among the countries that benefited from the Gates Foundation planning grant for SRS. And we plan to establish SRS to generate timely, complete, and nationally representative mortality data. And this SRS will be aimed to link community and facility death reporting and civil registration. So just a bit of gaps that we have currently experiencing as a country is that our death data collection and reporting are largely paper-based, fragmented, and mostly underreported. And as per our civil registration report, KVSR of 2024, our registration completeness was at 44.8%, with a lot of deaths being registered from the community. So also in terms of cost of death data, we currently do what is known as lay reporting, and it is often inaccurate. All these gaps combined hinders our surveillance and also missed community deaths as well as unreliable cost of death data. So this impacts our effective public health response, planning, and resource allocation. So SRS comes in to link the civil registration process and the health sector reporting of death. And this will provide timely data for surveillance and improve death registration completeness. The incorporation of verbal autopsy also into the SRS will help enhance the quality of course of death data. And the SRS, we plan to leverage on existing structures and systems to provide national representative data. So overview of our resource mobilization plan. The overall goal is to ensure sustainable financing and institutionalization of SRS beyond the initial donor support. So, and the approach we are taking is to be a government-led process that is partner aligned and a phased financing strategy. Progressive transition from donor funding to domestic resources, and integration of SRS into existing CRS and MOH systems and budgets. So just to break down the funding sources and types, we have our Government of Kenya, which currently under the MOH and the civil registration, which is under the Ministry of Interior, where we have budgetary allocations that goes into various components, including human resource, supervision, and digital systems. We also have in-kind support in forms of infrastructure, hosting of the system, including staff time. We also have the aspect of development partners, where we have direct financial support, and this goes to startup, scale up, and innovations. Then for technical assistance as well for our development partners in aspects of different areas of SRS, include the verbal autopsy itself, meets and analytics and capacity building as well. So given our devolved system, we will also have the counties, which are autonomous by themselves and will engage the Council of Governors and the county health management teams into supporting SRS for co-financing, especially for community level operations and supervision, and also support for community health promoters, which are community health workers, and support of data review meetings as well and local dissemination. We also have academia and other research partners and contribute largely into supporting analysis, training, and include of data use as form of research. So for status of our resource mobilization, we conducted funding landscape analysis as part of our situational assessment, and we mapped out our stakeholders. And also part of this process, throughout the planning process, we have been engaging key stakeholders and partners, including the Africa CDC, WHO, US CDC, IOM, and have been very key in supporting us technically in developing the process itself, even including supporting some of our meetings and venues. So in terms of certainty of funds, we have what we have as high certainty or confirmed funds, and this from the government commitment to institutionalize SRS within the CRS and MOH. And out of the 100 cost estimate that we came up with for full SRS implementation, the government commits up to 84%, while we seek the remaining 16% from external funds. So high commitment also comes from our digitization initiative in our country to integrate our community health system, our health facility system, the civil registration system, and the whole data, national data infrastructure. And these resources are assured through our midterm expenditure framework, which is a planning financial tool for the government that allocates funds into prioritized areas. We also have the already resource mobilized resources within the Kenya National Public Health Institute. For medium certainty, we have partner support, and we really appreciate the startup that the Gates Foundation supported us in providing the planning funds, which has created really a good platform for us for further partner engagement. We also have the county level co-financing that we aim to also explore in selected implementation areas for SRS. For what remains to be mobilized will be the funds for full national scale-up course and other areas, including analytics, research, and long-term evaluations. So just what we have done so far in terms of partner engagement, we have been engaging our partners all through the planning phase. And last year, we had an opportunity to meet, to have a stakeholder meeting with partners themselves. And we managed to present our business case, showcase our value proposition for SRS and multi-sectoral benefits. And we were able to really showcase the value of SRS, and we had a way forward agreed upon. And there was really keen interest from different partners to really support SRS. We also aim to explore the current agreement between the government of Kenya and the US government, bilateral global health security agreement. And through this, we'll have to have a structured mechanism where we'll incorporate SRS into this co-financing and align our priorities with surveillance, data system, and pandemic preparedness. So for post-proposal submission, we categorize this into 4 aspects. And really, we want to continue with our partnership and resource alignment and partner engagement. We want to engage our partners to align SRS and support and their upcoming new budget cycles, and really tailor our concept notes into their strategic interests and priorities. Plus, we also plan to continue with our follow-up meetings, this through our CRVS and mortality surveillance technical working groups. We also aim to really strengthen government ownership and integration. For this, we want to continue advocacy, really advocate for domestic budget allocations, both within the civil registration and the Ministry of Health. And also align some of our existing national and preparedness and response agendas with our SRS activities. We also want to continue with advancing policy dialogue around the use of mortality data. For system optimization, we continue to refine our workflow for SRS, specifically the IT workflow. Our IT experts are still currently having sessions with our TAs to really refine this process and the interoperability processes. And then also we aim to continue our surveillance using the existing platforms and enhance data use, and even continue disseminating our outputs and mortality data through our mortality bulletins and surveillance bulletins existing within our structures. Then also want to continue with knowledge, evidence, and advocacy. We want to showcase and document our SRS processes and share through our Kenya National Public Health platforms, including our newsletters and other platforms, for the purpose of visibility and to allow the youth and even really advocate for SRS and showcase what we are currently doing. Also, we want to leverage on the lessons from our VA pilot. We had verbal autopsy piloted in counties, and we aim to use these outputs, really look at what we learned so that we incorporate this as we look forward to implementing SRS, as well as other projects, including the CHAMP sites projects and other mortality surveillance projects in the country. We also want to develop policy briefs. Last year, we had an opportunity to do.
I'm sorry, I think I have to interrupt because we are a bit beyond the time. Maybe can you wrap it up, please?
Sure. So I'll also wrapping up. So we want to continue with these 4 aspects for submission of our activities. Just to conclude, we remain committed to institutionalizing SRS in our country, and our next phase will focus on coordinated resource mobilization and shared investments. And over time, we want to transition our SRS operations to a fully government-financed platform to improve our mortality evidence and strong population health outcomes. Thank you, and Asante.
Asante, thank you very much, Mercy. We'll now move on to the next country. Maybe I ask from my side to the presenters is to please stick to the time we are ready to present. We want to hear from all of you. So, Mercy, thank you very much. We'll have questions if we have time at the end. And now we move to Pakistan with Dr. Mariam Sarfaraz.
Hi, good evening. I hope my slides are visible.
Yes, they are. We see the PowerPoint.
Let me just put it on full screen.
Yes, now it's
right. All right, great. So thank you for the floor and thank you for the opportunity to discuss our plans for post the planning grant time frame. So a little bit of a background about Pakistan. Well, although many of you might be aware of it, Pakistan is a low and middle income country. It's the 5th most populous country in the world. The male-female ratio is 105 males to 100 females. 65% of our population lives in rural areas where the infrastructure availability is limited and fractured. The fertility rate is quite high at 3.47 births per woman. Geographically, ethnically, and linguistically, it's a very diverse country, and it's quite large, both in terms of population and in terms of the geographic area which it covers. And with specific reference to health, there are many inequalities which exist, including life expectancy differences, the health. The Delhi's are different for different regions. There are the social development index has not increased over the past 3 decades, and it is sort of like at a stagnant number. Coming specifically to the civil registration and vital statistics in Pakistan, there has been a registration system in place in the country since 1947, but it is interrupted. It is like I said, fractured, and it does not capture all the deaths and the births and other vital events. So in the year 2000, the National Database and Registration Authority was developed with the specific purpose of streamlining the birth and death registrations. Birth, death, and other vital event registrations, migration, marriage, and all those. However, the system for registration of births and deaths is still not comprehensive. The database, which was developed in 2000, it is a separate entity independent entity, and it is not directly linked to either health or other concerned ministries or departments where the vital events are registered. There is no system for reporting the complete and accurate causes of death, like the numbers, the coding for ICD coding for it. The quality of those which are recorded is not optimal. They are just generic causes are written there. And not enough value is placed on recording these causes accurately, and hence the low sort of attention to detail in terms of birth and death registration. In terms of the actual position on ground, the last Pakistan Demographic and Health Survey of 2018 shows that only 42% of children under 5 were registered, and only 36% of the children had a birth certificate. Then there are several factors basically which govern the whole civil registration vital statistics work in Pakistan, and this includes reporting pathways, notifiers, local governments, NADRA, the database and registration authority, and its coordination with other departments like the Planning Commission, like the Ministry of Health, Ministry of Interior, and overall governance mechanisms within these separate departments. Uh, while there are these challenges and lacuna and such system gaps, there are certain legal frameworks which are available in the country. There is a foundational law which is the Act of 1886. However, it's a voluntary registration act, and the enforcement for it is weak. There are federal legislations as well which have been enacted, like the NADRA ordinance to develop the registration authority. Then there is the Reorganization Act, which allowed the Pakistan Bureau of Statistics to take some responsibility for analyzing and looking at the national vital statistics. However, there are several inconsistencies in the legal scope, in the enforcement, and the procedures at the provincial level. So Pakistan is a devolved country where the provinces have their own policies and approaches, so there is a fragmentation at that level. So keeping this background in mind, the planning grant for establishing SRS in Pakistan was initiated, and NIH, Dr. Faiza is leading it. She's the country PI for it. So within this planning grant, there was some activities which were done, and they gave us certain very important lessons for institutionalizing SRS and strengthening the CRVS within the systems. The reason for having the mortality surveillance, SRS as a mortality surveillance, is basically that we have a huge population. Deaths outside the healthcare systems are still not reported and recorded. There is a limited community buy-in, and there are overlapping mandates of multiple organizations, including both public and the development partner sectors. There are system gaps, such that there is a lack of coordination between the departments. The coverage of the registration authorities is limited. There is under-reporting, and the legal framework inadequacies are mainly lack of framework in some provinces, and also weak enforcement in several areas. The SDG goals, we are not really able to meet the targets defined, which is of 100% birth registration and 80% death registration. We are quite low in that, lying between 40 to 60% for birth and death registrations. There are certain reform efforts in place, which includes the CRVS policy of 2020, the digital birth registration processes put in place. Certain pilots have been done for verbal autopsy, and considering this background, the way forward was having the SRS system for mortality surveillance institutionalized and developed within the country. So with the planning grant, The extensive stakeholder engagement had been undertaken. The situational assessment was done both using the document available and through in-depth interviews with the key stakeholders. A process mapping was conducted, and following that, a process was defined. Then the process for actual registration of deaths was mapped. Using that, a proof of concept was developed to strengthen the mortality registration and surveillance. And based on the results of phase 2, a costed implementation plan was developed. Now, within the proof of concept, the proof of concept was conducted in a region, in a small region within the capital of Pakistan, Islamabad. The area is called Barako. The focus in that proof of concept was to use the existing infrastructure and the existing, you can say, human resources and systems in place to strengthen the death notification, to conduct verbal autopsies, and then do a coding of that so that accurate cause of death can be recorded. And the proof of concept has been quite valuable in supporting the development of the design for the sample registration system. So the proposed plan is to establish a nationally representative vital events surveillance system using community-based approaches and using the existing infrastructure, develop standardized digital tools, SOPs, and trainings, generate reliable ICD compliant cause of death through verbal autopsies and medical certification of cause of death, integrate seamless integration, implementing a phased rollout and scale up, translating pilot learnings into national costed roadmap, and establishing a robust governance and financing model with all the roles for the all coordinating agencies and stakeholders well defined. Now, I will not go into
Maybe,
the details.
sorry to interject, Mariam. Maybe for the sake of time, perhaps you could get to the funding landscape really
Yes,
quick.
that's what I'm going to now. That's what I was exactly saying, that I'm not going to the details and get directly to the funding. So we have the current funding landscape which we are facing is a dual challenge. The domestic funding is through two streams. One is through the project-based and time-bound projects, and the other is the recurrent funding through which goes to the health system, to the health ministry, to the provincial health departments, Ministry of Interior, and the Planning Commission. But they are limited funds, and their volume has not increased significantly over the past years. The international funding, which is through development partners, through UN agencies, through multilateral, bilateral agencies, it has been a lot, but it is fragmented, and it is not a continuous sort of a thing. It comes and goes, and that's this is a missed opportunity for synergizing the funds. So keeping this in mind, we have we developed an approach to mobilize resources through engaging with the key stakeholders, and these included the federal government. You can see the second column has the different roles and the focal points, through provincial authorities, multilateral agencies, bilateral donors, academias. We engaged with them for increasing the funds allocated, for developing some sort of a recurrent budgets which represent a foundational commitment on behalf of the government. At the provincial health authorities, since there has been the evolution, the engagement was done with the health department, with the planning commissions, for integrating the budgets for birth and death registration within the existing system and enhancing it over the years. The multilateral agencies were approached with the purpose for having funded proposals, targeted and strategic proposals for technical assistance and for strengthening the existing CRVS system and the capacity development within the system. Bilateral donors, again, their support has been the engagement with them has been to support the health outcomes, governance, and data availability. The local research institutions and local NGOs would be providing the technical support and evaluation, and several other forms of engagements which would be required to synergize the funds which come through all these stakeholders. Now, the gaps which we have identified, there are operational and staffing costs since the funds are inconsistent and the remuneration for enumerators, supervisors, and for conducting a continuous training program is limited. Then there are infrastructure and logistic gaps. There are still a lot of manual entry, so the transfer to the digital data collection platforms and real-time data capture and cloud-based storage is a major area which needs investment. The cause of death records, medical coders, and whosoever within the health department who does the death certificates, they lack training on the cause of death as per the COD, as per the ICD standards. Community awareness is also low. There is a very low buy-in from them as they do not see the benefit of registering a birth or a death. And the sustainability, long-term sustainability, would again come through the government's commitment and the support in terms of financial terms, which comes both from the federal and from the provincial departments to the health systems and to the vital registrations departments. Now,
Mariam, I'm sorry, could you also start wrapping up? We still have like
yes,
another four countries.
just
I
have
think
last two slides. Yeah.
perfect. Thank you very much.
So our next steps are number one, institutional mandates for mortality surveillance and development partners. So we are trying to leverage the technical and financial commitments from the UN organizations, which include UNICEF, WHO, UNFPA. They're already working in CRVS, but again, it is fragmented. So our target we have engaged with them to synergize the fundings, develop a unified approach and action. With the World Bank, our talks have been to prepare and fund multi-year programs through existing, perhaps as part of the existing programs or through new proposals to address the systemic, operational, and infrastructural gaps and utilize the SRS as a standardized monitoring tool for measuring impact. With the existing departments, which includes the Bureau of Statistics, Health Ministry, NADRA, donors, we look forward to we are working on developing establishing a high level multi-sectoral technical working group for strategic guidance, governance, and the major part of the next steps is domestic resource mobilization through using innovative funding mechanisms. One of them is the revising the IDSR project proposal to include not just to include mortality in it as well, especially due to infectious diseases, and also develop new PSTP projects, which is the costed action plan for the next 5 years. Work on a blended financing modalities. Engage the private partnerships to mobilize resources to the private sector and the philanthropic sector as well to supplement the traditional funding and ensure long-term sustainability, as Pakistan has committed to improving integrating SRS system and improving the CRVS within the country. So this is my last slide. Thank you very much.
Thank you very
Dr.
much.
Faisal, if she wants to add something, she's online.
Yes, I think I'm afraid we have to move on to
Okay.
the other countries,
Sure.
but thank you. Okay, yes, the next one is Senegal with Dr. Titiane. Santiago will have English-French interpretation, so please tune in to the corresponding channel. Dr. Titiane, c'est à vous. C'est à vous. Merci.
Bonjour, est-ce que vous voyez mon écran?
Oui, oui, on la voit, mais pas la présentation.
Tu peux mettre en mode diapo.
D'accord.
Vous voyez l'écran?
Ouais, ouais. Parfait, merci.
Très bien. Donc, merci. Je vais partager avec vous la présentation du Sénégal portant sur le plan national multisectoriels budgétisés dans le cadre du projet SRS. Donc, en insistant sur la mobilisation des ressources conformément aux orientations qui ont été reçues pour une présentation de 7 minutes. Voilà, donc ça, c'est le plan que nous allons vous partager avec le plan de mise en œuvre du SRS, les différents axes, le budget allant jusqu'à l'état actuel et le niveau de certitude du financement. Juste rappeler que par rapport au SRS au Sénégal, donc nous allons nous intéresser aux naissances, aux décès, mais également aux causes de décès. Et la mise en œuvre du SRS au Sénégal se fera en 3 phases. Une première phase qui sera une phase pilote qui va se dérouler sur une année et portera sur 2 régions parmi les 14 régions du pays. Ensuite, une deuxième phase va se faire au niveau de 7 régions et la phase 3 sur 2 ans va toucher donc l'ensemble des 14 régions du pays. La mise en œuvre de SRS repose au niveau du pays sur 4 axes stratégiques. Donc, et comme premier axe, c'est la gouvernance et la coordination. Deuxième axe va porter sur la collecte et l'analyse des données. Et le troisième axe, c'est l'engagement communautaire et le suivi-évaluation constitue le dernier axe. Juste préciser, pour l'ensemble de ces phases, donc chaque axe est composé de différentes lignes d'action qui sont décrites. Maintenant, par rapport au budget du projet SRS pour les 3 phases au Sénégal, donc ceci est budgétisé pour un montant de 17 723 000 $ et réparti, comme vous le voyez sur ce diagramme en camembert, avec les 3 phases, donc où la phase 3 va occuper 59% du budget global et la première phase, qui est la phase pilote qui doit se dérouler sur une année, donc occupe 9% du budget à hauteur de 1 658 000 $. Maintenant, si on fait la répartition du budget par axe stratégique qui sous-tendent ce projet SRS, nous voyons que pour la première phase, l'axe stratégique collecte et analyse des données occupe 62% du budget et c'est la même chose pour la phase 2 et la phase 3 où l'axe collecte et analyse des données SRS avec les naissances, les décès et les causes de décès, donc occupe la plus grande partie du budget. Donc, ces 3 figures montrent la répartition donc, du budget par phase et par axe stratégique. Si on va également à la répartition du budget par source de financement, nous rappelons que le Sénégal a eu à faire plusieurs rencontres avec les partenaires techniques et financiers pour avoir donc leur engagement dans le cadre du financement de ce projet SRS. Et c'est à partir donc de ces rencontres que nous avons fait la répartition donc du budget par source de financement. Donc sur les 17 millions de dollars pour les 3 phases de ce projet sur 4 ans. Donc, nous voyons nettement que nous attendons fortement euh, une participation de Gate Foundation à hauteur de 41,9%. Les autres partenaires et l'État également du Sénégal se sont engagés à financer donc certaines activités. Donc, ce tableau montre la répartition donc, du budget par source de financement pour les 3 phases. Maintenant, si on fait une désagrégation des sources de financement pour chaque phase, pour la première phase qui est très déterminante, donc pour cette phase qui est donc sur le diagramme en camembert, donc sur cette phase tourne autour de 1 658 000 $. Et nous attendons donc une participation de Gates Foundation à hauteur de 64,5%. Les 35% restantes, donc ça, c'est une partie qui est déjà disponible et mobilisée autour donc d'autres partenaires tels que la Fondation Buffett, tels qu'également la Banque mondiale, à travers des projets qui sont mis en œuvre donc au Sénégal. Et pour chacun de ces partenaires, donc, il y a un montant et un pourcentage qui est dédié pour la mise en œuvre de cette phase pilote. Donc, cette phase pilote, elle est importante, elle est déterminante parce que c'est à partir des résultats de cette première phase pilote que les phases 2 et 3 pourront donc être financées avec d'autres partenaires qui se sont déjà donc signalés et engagés pour appuyer donc le Sénégal. Maintenant, la stratégie de mobilisation des ressources pour le pays, cette stratégie repose sur 4 points essentiellement. Le premier point, le Sénégal compte sur l'intégration du SRS dans les priorités nationales. Donc, SRS sera inscrite dans le budget programme du ministère en charge de la santé, mais également il y aura un alignement de SRS dans le plan stratégique du système d'information qui doit être élaboré en fin d'année 2026 et portera sur 2027-2031. Autre chose également pour l'intégration dans les priorités nationales, SRS donc s'appuiera sur une mobilisation des budgets déconcentrés, surtout avec les comités de développement sanitaire. Le deuxième point essentiel pour les stratégies de mobilisation des ressources, c'est l'assurance de la durabilité. Pour que SRS donc puisse être mise en œuvre correctement, il faut qu'on soit sûr qu'il y ait une bonne durabilité. Et pour ce faire, donc, nous comptons renforcer l'appropriation nationale du SRS à travers son intégration dans les plateformes nationales comme la plateforme DHS2. Le troisième point de la stratégie de mobilisation des ressources, c'est l'engagement ciblé des partenaires. Il y a une multitude de partenaires au niveau du pays, mais nous en avons ciblé donc certains qui pourront appuyer le pays en fonction de leurs priorités. Et le Sénégal, donc, va faire pour chaque partenaire une note d'investissement. Et les partenaires ciblés concernent donc la Fondation Bill et Melinda Gates, mais également la Banque mondiale à travers certains projets qui sont mis en œuvre ici au pays, tels que le projet PIFOR, tel que le projet également FASAO, mais la Fondation Buffett également, qui appuie la qualité des données, donc va recevoir une note d'investissement ainsi que les autres partenaires tels que Vital Strategy, UNICEF et Expertise France. Et ces différents partenaires qui sont en bas, Vital, UNICEF et autres, donc se sont beaucoup plus engagés à partir de la phase 2 donc, du projet. Juste pour rappeler que la phase 1, qui est la phase pilote, est déterminante pour le pays pour pouvoir donc dérouler les 3 phases de ce projet SRS. Et le quatrième et dernier point de la stratégie de mobilisation des ressources, c'est le cofinancement et le plaidoyer. En tout cas, il y a un fort engagement de l'État pour faire donc un cofinancement à travers la gouvernance, la coordination et les ressources humaines. Maintenant, nous sommes dans un projet de plan et une planification. Il va falloir donc qu'on mette en place différents scénarios. Et c'est pourquoi le Sénégal a proposé 3 scénarios. Le premier scénario, c'est lié à un financement donc optimal disponible. C'est-à-dire si tout le financement qui est prévu est disponible pour les trois phases, donc nous allons mettre en œuvre ceci pour 2026 et 2029 en restant sur les 1310 districts de recensement donc tirés. Par contre, si aujourd'hui le Sénégal donc ne dispose pas d'un financement total avec un financement partiel, donc ce qui va se faire, il va falloir qu'on adapte notre stratégie en maintenant la première phase pilote pour les 2 régions, mais par contre, la phase 2 sera réduite et au lieu de passer donc à 5 nouvelles régions, nous allons nous limiter à 3 régions. Il y a également un troisième scénario où le financement est limité, c'est-à-dire nous n'avons pas toute la disponibilité donc, du financement. Dans ce cas de figure, on compte mettre juste donc, la phase pilote, la phase intacte. Et ensuite, les autres phases 2 et 3, elles seront repoussées pour les années suivantes. Maintenant, pour terminer, l'état actuel et le niveau de certitude du financement. Nous pouvons dire que pour la première phase, qui est la phase pilote, qui doit se dérouler sur une année, un montant de 1 658 000 $ donc est nécessaire. Et pour ce faire, il y a quand même la disponibilité d'une proportion qui tourne autour de 35,5% à travers donc la fondation Buffett, la Banque mondiale avec ses différents projets, mais également l'État du Sénégal. Donc, il reste juste pour cette première phase qu'on ait donc un montant avec une proportion de 64,5% du budget nécessaire, donc qui sera donc mobilisé et on l'espère à partir donc de BMGF. Maintenant, pour les phases 2, et les phases 3, donc nous avons des engagements donc des autres partenaires tels que l'UNICEF, l'Expertise France, la Banque mondiale, et nous pouvons mobiliser jusqu'à 40% du budget des deux phases en fonction donc des résultats de la phase pilote en dehors du financement de l'État. Voilà donc ce que nous devions présenter pour le compte du Sénégal. Merci.
Merci beaucoup, Dr. Tidiane, and thank you for the presentation. I'm having a look at the time, and we will be running way above the 1 hour, the 60-minute clock. So what I would suggest is maybe we open up to question and answers now for the next 13 minutes to closing time, and we can reschedule the other three presentations from Tanzania, from Ghana, and from Mali for the next webinar. So I'm very sorry about that, but I thought it was it's probably best for everyone, and that also gives us the opportunity for now to ask some questions. So maybe for the countries to ask one another, or the TA, the technical assistance team, to ask for clarifications, and or for any participant to share any suggestions related to resource mobilization strategies.
Patricia, can I ask a clarifying question? Are you saying that we will not be presenting today, or after the question we'll continue?
L'interprétation est désactivée apparemment.
Yes, yes. So we have like 60 minutes, and we ask the countries to have like a 7 to 8 minute presentation. But there is a lot to share, and I know it's very difficult to stick to the times. So and so many of the countries have gone above the slot. So what I suggest is that you can work on your presentations further until the next webinar next month. But if you have any questions related to your resource mobilization plans, or anything that you would like us to call, we can also have some side meetings with the technical team. But then with the whole SRS community, I suggest we table that for the next webinar, so you also have enough time to present, and we don't have to stick now to the 7 or 8 minutes, but you can have like a 10 or
Patricia,
15
nous avons
minute
perdu
presentation.
l'interprétation.
Ça marche? Ça marche maintenant?
Non.
Peut-être que Moni marchait. Non. Non, ce que je viens de dire, c'est qu'on va postponer la présentation de l'autre pays, donc la Tanzanie, et Mali et Ghana pour la prochaine fois. Et maintenant, on peut faire un peu questions et réponses pour les dernières 10 minutes, si ça marche pour tout. So is there any, otherwise, if there are no questions, we can also move on to the presentation from Ghana, from Professor Bawa. Are there any questions? Okay, if not, Professor Bawa, would you like to present? I hope you can hear me now. Professor Bawa, are you still there? Or if anyone has any questions, please feel free to post them in the chat. Maybe to the countries who presented already, any clarifications. No, I think I don't know, maybe Professor Bawa, you're not able to hear me. Then I would suggest we move on to Tanzania for the last presentation. And I believe it was Gisbert Misbah. Sorry for mispronouncing the name. Yes, okay, thank you very much. We'll have like 10 minutes for the presentation. Thank you.
Okay, thank you very much. Do you hear me? Okay, good. Can you put in presentation mode, Imrema? Well, so this is Gisbert Msigwa. I will be presenting on resource mobilization for sample registration system implementation in Tanzania on behalf of the SRS technical coordination team. So we will be going through the following outline. Number one will be on mortality data challenges in Tanzania, rationale for investment in SRS, government commitment and domestic resources, strategic partnership, and lastly, conclusion. So starting with mortality data challenges in Tanzania. Next, Timber. So we do have a decline in completeness of CRVS death registration. This is from the assessment that we had completed in a few months ago, that there is a decline in death registration completeness from 6.6% in 2021 to 4.4% in 2023. There is 15% of deaths from health facility that are medically certified in 2023. So all these are from the published statistics already. There is mortality data, systems that are spread across across the country, which are fragmented. For instance, the CRVS, HMIS, CRVS, VA, IDSR, MLDI, and MPDSR system as well. There is an active multi-sectoral technical working groups, such as the CRVS Technical Working Group and the Mortality Surveillance Mortality Technical Working Group as well. There is no system that provides comprehensive population level mortality data for evidence-based planning and decision making as well. Next slide. Mrema, can you go to next slide? Well, so on rationale for investing in the SRS, we will be addressing data gaps in vital statistics. This is due to that significant challenges in producing timely, reliable data on birth and deaths as well. And this is specifically on completeness of births and birth and death registration as well. Improving on mortality surveillance, we will be establishing a mechanism to capture all cause and cause-specific mortality, supporting evidence-based policy and planning as well. On reliable mortality estimates, these are really critical for resource allocation and priority settings as well. We'll be leveraging the existing government structures by integrating SRS with the registration agency and building on the experience of the previous systems that we have been implementing, of which IHI has been implementing with the ministry in collaboration with the Minister of Health. We'll be catalyzing the CRVS data systems integration to make sure that we are not building the new systems for SRS implementation. So with the resource specific mobilization, we have come up with two major areas. Number one, it's on government commitment and domestic resources. And specifically, we will be using the existing government structures, including the human resources at all levels of administration, starting from the points of data collection, whereby we will be using the community health workers, and on the supervisors to district level, regional level, and national level as well. We will be using those that have been employed by the government. Government buildings and other infrastructures, including the vehicles, will be used. That's the ones that have been purchased by the government already. We'll be using the existing IT and digital solutions like servers, computers, and tablets. And this is specific to the areas that are already implementing verbal autopsy through a national scale up, whereby there is an overlap. And in some of the enumeration areas where there are other government interventions that are ongoing, and we already have the tablets there. But the regional, district, and national coordinators will be using the existing computers as well that they are currently using for data-related tasks. Specifically on budget allocation, to support SRS implementation, the system maintenance and operational costs will be leveraged, the ones that the government has budgeted, and the budget of which the government uses to make sure that it maintains the existing systems like DHIS, IDSR, and so forth. On fieldwork supportive supervision, we will make sure that we integrate SRS with existing plans of data, routine supportive supervisions that have been planned to be implemented on a quarterly basis. There are some of the resources that have already been put in place, specifically on data analysis, dissemination, and use. And examples of the reports that are being produced already are like the annual health sector performance profile report and the annual mortality statistics report as well. So once we work on these reports, we will make sure that we include the data from SRS side as well. Another part is on strategic partnership, whereby we will be leveraging the partnerships with the key development partners, including Gates Foundation, who has already financed us on the budget to develop the SRS proposal. And we have indicated in the proposal that we will be implementing SRS through the budget that we have requested from that side as well. So we have Global Fund, who has already committed some funds on VA implementation, of which kinds of resources will be also used in SRS implementation, because we do have some of the activities that do overlap, like supportive supervision, data analysis, and so forth. We have Vital Strategies, of course, who has been supporting us throughout the proposal development by providing the TA, and we are hoping Vital Strategies will continue during the implementation stage. The other funders that we're looking forward to approach them to make sure that they buy in the SRS implementation are like UNICEF, World Health Organization, Africa CDC, and the US CDC as well. Another part is to use the existing governance mechanism, specifically ICT M&E Technical Working Group, whereby we will use this platform to make sure that we coordinate different partners in SRS implementation, ask for finance and technical commitment, and align with SRS national priority. Next slide. Bremer. So this is a summary of what I have presented above. This slide indicates the type of sources type of funding and level of certainty, of which those that have been mentioned on the side of the government have already been confirmed. Next slide. The other slide speaks about the type of resources that we are anticipating to receive or to ask for the support from other donors. So up to now, it is not confirmed. Next slide. So we are looking forward to come up with the following steps. Number one, to continue with advocacy within the government on SRS budget allocation. And the other one is to make sure that we prepare the stakeholders meeting to make sure that we engage those partners that are not yet on board to ask for their commitment in terms of resource allocation for SRS implementation. And to conclude, next, Mrema. So we believe SRS co-financing is key to sustainability. Accurate, timely, representative mortality data are integral to public health and developmental planning. SRS is a cross-sector public good that can bridge mortality data gaps. And finally, the defining features of SRS can be used to engage multiple stakeholders across multiple sectors. Thank you very much. I submit.
Thank you very much to you, Gisbert, for the timely presentation, for sticking to the time. And I won't keep anyone here longer. Thank you very, very much for the presentations, to the presenters, and especially to those who didn't have the chance to present today. We will make sure that you get the chance to present next time, or we'll see how we organize that. But thank you everyone for being here. We appreciate everyone's engagement, and we look forward to continuing these sessions in the future. Have a good rest of the day.
No, I just want
Thank you. Thank you, Patricia. Bye-bye.
Thank you,
Thank you,
Patricia.
everyone.